All right. We're live. Good morning, good afternoon, good evening, depending on where you are when you watch this. This is the face and voice of Dr. Tolu Olabintan, CEO of Living Spring Family Medical Center here in the city of Mansfield, Texas, where we believe in helping you live long and well, because we believe that the quality of life or the quantity of life is just as important as the quality of life. I'm really excited to be here with my friend and pain specialist, Dr. Sarah Merritt. Thank you so much for being here. We're honored to have you.
Thank
Yeah.
you. Thanks for having me.
And now, for those who are watching live, do me a favor, hashtag live. And for those who will watch this as replay, hashtag replay. And of course, I encourage you to share this with friends and those who would find this useful. All right, over to our guest, Dr. Merritt. Please kindly introduce yourself to the guests. Who are you and what do you do?
Yeah, my name is Sarah Merritt. I'm an anesthesiologist. I trained also in pain medicine, and that's most of my practice is actually managing pain on an outpatient basis. We treat in my outpatient practice, we treat patients with acute and chronic pain. We manage medications, we give injections. And then as a result of practicing in this area for a period of time, I got interested actually also in addiction medicine, because if you treat patients with pain, at some point you're going to also intersect with patients who have a substance use problem. And so I ended up getting board certified also in addiction medicine. So most of my practice is in pain management, but we do also have a portion of the practice where we treat patients with substance use disorder, mostly patients with opioid use disorder, but most of my practice is toward pain management and helping patients live better lives despite chronic pain.
Awesome. I like what you do, Doc, because pain is a pain.
Pain is
Like, I love what you do. And thank you for what you do, I'd say. Now, my next question is why do you do what you do? Like, I'm curious, there's a story behind it. Like, how did you get to decide, like, this was the specialty of choice for you?
Yeah, that's interesting. Yeah, it was not something that I set out to do like first thing in training. I did think I want to be a doctor even from a young age as a kid. But I didn't have a specific idea of what type. And I had kind of a journey through trying some different specialties. And really, I got into anesthesia and not sure if I was interested more in the pain side or the anesthesia side, but I knew I liked both. And I had a mentor. And so Dr. Pamela Vick was my mentor at the University of North Carolina. And she said, you don't know it yet, but you want to do pain. And she was just a great mentor and somebody who really enjoyed the work herself. And I would say, it can be challenging at times. There are, we deal with difficult problems. I think what I like about pain management is a lot of times if you can truly help a patient, who has a severe or significant pain problem, you've helped them with a lot of times their most significant thing, like what they feel is having the most impact on their life. And so, yeah, they've got blood pressure. Yeah, they've got diabetes. Yeah, they need those things managed by a primary care. But the one that they notice the effect of in such a real way is often that pain challenge. And so that's been very gratifying to me in my career, is to be able to make a difference there. And, frankly, like patients are grateful when we, take the time. That's part of also what I feel is important, is to try to have enough time to connect with the patient, really hear what they're saying. And even just like, like returning kindness to them is, I think, therapeutic in many ways, to have, a productive relationship. Sometimes our patients that have really had a lot of challenges, they may be, usually there's a lot of feelings wrapped up in having a chronic pain problem. And so they may have a lot of feelings about it. And so to be able to try to approach that with, scientific knowledge, but then also like a gentleness and some empathy, I feel like is strangely novel.
Oh, and patients can really appreciate the quality of work you do because you do it with care and you hear them, you listen to them, and you
we
address
really
their
try.
concerns. So that's big. I like what you do. I like what you do, Doc. Now, let's go right into it. What is chronic pain? How would you define chronic pain? Because that's what we're talking about today.
Um, so there's a definition of just pain in general that I think is helpful because so pain is a feeling of actual or perceived tissue damage. And then if it's chronic, it's going on for more than 90 days. And so if you break your arm, you're noticing, the tissue damage from breaking your arm. There are nerves and inflammatory type of things that will happen in that arm that will really let you know, hey, you've broken your arm. And that is, a physical tissue damage type of pain. Then there are kind of on the other extremes, that's an extreme example of that's a pretty big thing if you break your arm. On the other extreme, something that could also cause significant pain but might not be associated with tissue damage would be there are some different conditions, including some types of back pain, sometimes fibromyalgia. There's also a condition called CRPS, which is an inflammation in the nerves. And those are real pain conditions. They are real. They are painful. But there's not always ongoing tissue damage. And so that is what is hard. Sometimes for these patients, they might be in a severe level of pain, but there's less of an objective way to show or to convey what's going on. There's less evidence of it. And that doesn't mean their experience isn't real, but there's less obvious. There's just less obvious of reasons. So.
Okay. And I think you already touched on
what is chronic pain. Chronic pain is just pain from actual or perceived tissue damage that goes on for usually more than 90 days is kind of the cutoff. So if you break that arm, you're probably going to have some pain for several weeks or maybe a month. Will it go on longer than that? Hard to know. And then there's this healing process, and most people are going to be, a lot better or completely better in that 90-day period. And then if it goes past that, then you might fit that definition for chronic pain.
Okay. So there's that 90-day mark, regardless of what type of pain it is. Now, I know you already touched on some of the question I'm about to ask you on the different types of pain. What are the different types of pain for the sake of our viewers, so that we can kind of classify it better?
Yeah, there are a couple of types, and I don't always necessarily talk about this with patients, but I think it's helpful for patients to know because there are these different types of pain, and it dictates what treatments are best. Kind of the type of pain that we're all really familiar with from acute pain would be what we would call nociceptive pain, like NOCICEPTIVE, nociceptive pain. And so a nociceptor is a pain receptor. So that's just the kind of pain that you have if you break your arm that is, clearly through these pain receptors that are to keep you from hurting yourself. So that's one type. And if you have And some people with chronic pain will have areas like in the low back or in the neck. If you might have a disc that's damaged, you can get to a point where that disc doesn't change much. But a lot of times within the first, year or two of a serious disc injury, there will be small re-injuries that will cause flares. So that might even be a type of nociceptive pain, say in the low back or in the neck. So that's type 1. Type 2 is, and these are kind of like treatments that researchers and pain doctors use to help understand treatments and to provide treatments. Type 2 would be neuropathic pain. So if you have damage to a nerve. And so probably the most common type of neuropathic pain would be diabetic peripheral neuropathy, which there's a huge burden of pain from that. So any pain that is due to damage of a nerve. So in diabetic peripheral neuropathy, the peripheral nerves in the hands and feet have been damaged due to blood sugar abnormalities. and they can be numb and or painful. There are other types of neuropathic pain. Maybe sometimes we have patients who have had a nerve damaged, maybe in a surgery, whether a big nerve or a little nerve, and that will cause certain types of pain, and that's neuropathic pain. And then there's kind of this, when I was in training, we still used to talk about kind of those chronic pain syndromes where people have, long-term chronic pain, like fibromyalgia, like certain types of low back pain, as neuropathic, because clearly they were in the nervous system, right? Like you might have a patient with severe back pain. They have real back pain. It's not made up. That we don't look at pain that way. All pain is real. The patient with chronic back pain, where at some level just the nervous system starts to sustain the pain signal. And while there may be episodes of re-injury, there's also just like an abnormality in the pain processing system. And in fibromyalgia, similar, we think there are some abnormalities in the pain processing system that lead to this like dysregulated pain system that can give some people severe daily chronic pain. And so the name for that type of pain is nociplastic. And so noci is, right, we talked about the nociceptors is the pain receptor. And then plastic, if you've heard the word neuroplasticity, so something plastic is something that's changeable, that's moldable. And so it's this idea that, your nervous system can change. And one of the risk factors for chronic pain, and even for nociplastic pain, would be if you have a really bad episode of acute pain, and for instance, patients who've had like a mastectomy, that's a procedure that's associated with a high level of pain. And a lot of times there's also a level of psychological distress, right? Because this is a surgery that is unique to women with breast cancer. So that is usually a situation that might be stressful for that patient. So that procedure is associated with a high level of acute pain for that surgery. And then if you've been in the situation where you've had a high level of acute pain, that's actually a risk factor for that pain to be sustained longer. So that's one of the reasons we want to try to do a good job managing acute pain, is because then we can hopefully decrease the burden of chronic pain.
Chronic pain. Okay. So it matters who you see as a pain doctor.
Yeah, I think so. Yeah, for sure. I don't think, this is not, I think that you're going to get different results, different treatments, depending, on who you see.
Okay. All right. Just a hint. Now, what would you say are tips you'd give patients who have chronic pain on how to communicate with their doctors their pain from the physician standpoint?
Yeah, I think that's can be challenging. As the physician, I'm going to try to ask good questions, but I think it really is so helpful if a patient has kind of some clarity on their pain. Sometimes I'll see patients even bring, a list or a journal. I think that can be helpful. It also gives me an idea of maybe how long a problem's been going on. Otherwise, it kind of feels like, that moment in the exam room is kind of a snapshot, and to make sure that the physician has an idea about the scale of it, I think also it can be really helpful in terms of communicating to talk about, not just pain scores. A lot of times that's going to be asked, and that's part of the intake or the exam, is assessing a patient's level of pain. But you're also going to want to, I think it's also helpful to be able to tell the doctor about how it's impacting your life. So, as an example, I saw a patient this week who had gone from being able to, she had a big injury and fell off a ladder and had fractured her back. She had this nerve condition called CRPS of her hand. And then was really doing great in her recovery and had been able to walk 4 miles within, 6 months or a year after that incident. She'd really improved a lot. And then she kind of acutely went down to a stage where she tells me like, hey, I can't walk more than a block without needing to, sit down or to rest. And it turned out in her case that she had actually had a new fracture of her pelvis that was surprising really to all of us. But I think the take home message was really just not just like, oh, hey doc, I hurt worse, but being able to put it in really concrete terms. And that's kind of an extreme example of being able to like walk as far as anybody wants to walk, almost with 4 miles, to hey, I can hardly get across the house. But I think just even, especially if you have changes, to be able to describe those in functional terms is maybe what we would describe as that. So I think, functional impact of pain, and possibly journaling to help understand, what makes things better and worse, what correlations have you noticed? Those are helpful things to communicate with the doctor.
All right, very important. I tell my patients this a lot. It's good to, especially when I send them off to specialists, write down your questions, write down your concerns and how it affects, like you said, the quality of life. So that way the doctor is able to address your concerns as well. So
Yes.
Useful tip. And not just the pain, but how it affects quality of life, how it affects your functionality.
Right.
That's a big communicator. So big tip there. Thank you, Doc. My next question, as you alluded to it already, and of course we know pain can affect the quality of life, your activity levels, your mood, your ability to enjoy your hobbies, your work. Now, of course, this is not medical advice. This is medical information. Of course, we encourage you to see your doctor to have an individualized plan made out for you. But Doc, what are specific ways you would advise patients stay active, even with chronic pain?
Yeah, that's a big one. So I think it's really important that patients stay as active as possible for them. And I think really the question is, what's possible for that patient? And maybe there's where someone is right now. And a lot of my patients would like to be more active and do more. And while on the one hand, there are things like injections and medications that we can offer them. There's also the matter of, making sure that they stay active. I guess how do we help patients stay active? I think a couple of things. I would say, I like yoga, and I have done yoga personally, with some frequency for 20 years. And in yoga, sometimes we talk about your edge and, here's too much over here. And if you can kind of work all this area, that's okay. Eventually that edge gets bigger, like what you can do gets bigger. And so I would say that I talk to patients kind of with this in mind, although I don't tend to mention the yoga part, as we talk about, you need to make sure, we all know that you can overdo it. And what are those things that you can do, and make sure that you're doing them with some regularity. Because eventually, if you're working all that space of what you can do, eventually that space may get bigger. So even without saying like, hey, I need you to train for a marathon, right? Like that's just not realistic. That's like my example that I give folks, like, hey, no one's expecting you to, run a marathon. That's just not realistic. But, let's make sure that you're doing the things that you can do, because that those abilities can become less, right? Because we're all aging, and we need to stay as active as possible so we can, move on in life with as much function as possible. So I think that in terms of like specific activities, if a patient wants to talk about that, it's really just about finding something that works for you. I can think of a patient who sometimes he comes to see me in a scooter because he has a significant chronic back injury. But when he feels good, he has a little dog, and it's like a lap dog, and he'll walk the dog around the park. And sometimes we talk about, well, how much did you walk the dog this month? I have patients who like water or water therapy. And so I think particularly in the warm months, if my patients have access to a pool, being more active with that is certainly something that we suggest and recommend if that's an enjoyable way to stay active. Some patients like, cycling or indoor Bikes, a lot of times that's an activity that can be pretty tolerable even in patients with pain. And the reason is it just doesn't load the joints the way that, walking or running, right? You have to bear your own body weight. On a bicycle, you're really weightless in some respects. So it can help move the range of motion for those joints. So I think it's really a matter of like finding activities that work for the patient. And sometimes if patients aren't sure, we might even have them re-engage with, say, a physical therapist, because sometimes a referral to physical therapy can help come up with even like a stretching regimen or, some exercise that is helpful to do on the daily or for exacerbations of pain.
Awesome. You've dropped a lot of gems here, and the big, a lot actually. I hope people go back and rewatch this. But you talked, activity that you can tolerate, activity that also helps with your pain, because the more active you are, the more active you will remain, essentially.
That's right.
And of course, it's unique to each person, and there are
It
ways to encourage or enhance that. And I love how you talked about the zone of, well, this is too much and this is maybe the least you should do, and somewhere in there finding that balance. And of course, physical therapy can also help too. And weightless exercise, so exercise that doesn't have too much weight bearing, like in the pool, and on a bike. So there are ways, and I tell some of my patients, you don't have to stand up to exercise. You can actually sit and exercise.
That's a great concept for sure. And in fact, sometimes it might even take more strength. If I think about like sitting here in the chair and doing a leg lift, I'm going to need to engage my core. It can still be very activating to do chair exercise. Absolutely.
All right. I have a question, actually a comment from a patient. Hi, Dr. Uday. Thank you for joining. And Dr. Una also joined. Thank you for joining, Dr. Una and Miss Carmen as well. So someone mentioned, good job. She said, aging loved ones battle with pain is real. One is living with me, and it is a battle between their immobility, hearing loss, lack of energy, and lack of vocabulary to describe their pain in plain language other than their native language. Now, I know that there are other ways to communicate pain. I guess facial gestures. What would you say to that to encourage better communication between that patient, their doctor, and of course their loved one?
Yeah, I think that can be challenging, and I do have patients like that where they may have a native language other than English. It might be an elderly patient. I definitely have a few of those. Often, if a family member is comfortable to help with translation, that would be often what happens. And in my practice, we also have a third-party translation app that we can use if it's needed. The family member is often so helpful because they have seen the functional impact, right? We talked about the things you can and can't do. The family member has seen that functional impact. And so you really, versus the translator where you get this very dry word for word translation, you get that family member helping with the communication. And, I think that is valuable. I wouldn't, devalue that. On the one hand, I think the family member, oh, hey, I want you to advocate for yourself. Yeah. And do that as much as possible. But it's okay for that family member to maybe need help advocating for themselves if they're not able to put it in English, which is presumably maybe the doctor's language or a language that the doctor speaks. I think it would make sense to use that help.
Awesome. And I like that you said also communicate what are things you're not able to do that you would like to do. As a way to communicate level of pain or level of discomfort with the chronic issue. Thank you very much. And thank you, Dr. Uday, for that comment. Next question. Now, medications have a place, and we're not talking medications particularly here. They have a place of helping pain, but let's talk all other modalities. There's a debate, ice and heat.
Ice and heat.
What would you say, Doc? Should I use heat? Should I use ice? I hear both. What should I do? What would you say?
I would say for something that's more acute, I would tend to start with ice. So even if I do say an injection on a patient, I might tell them, if you feel like some ice today, you might do that because we poked you with a needle. And so there may be some discomfort in the area.
Mm.
So an acute injury or re-injury, I think I generally like ice. There is some data around looking at patients with just, what about my day-to-day chronic pain? That really either one, and frankly, there's a little bit of just patient preference is okay. There is some data around arthritis that ice is helpful. It has been shown in studies that, and you would think like, oh, arthritis, well, that's a chronic problem, but certainly it is something that can have flare-ups, et cetera, and ice can be helpful in reducing pain level, the burden of pain. So I think there's a little bit of patient preference, but yeah, for injections, injuries, arthritis, maybe starting with ice, but if that doesn't work for you, heat is fine. And a lot of times for patients with myofascial pain, pain in muscle areas, which is common in fibromyalgia and certain types of back pain, heat, and actually specifically there's something called moist heat, where, and a lot of times they have this at a physical therapy office, where they have big packs that can be moistened and placed on the body. And there's something about that moist heat that I think just helps it penetrate in a nice way into the muscle tissues and really can feel good.
I agree with you. I like those, the heat. But when I come home, my back, I use ice. And it feels so good. It's like a numbing effect. So whatever works for you, try it.
Right.
Whatever works for you.
And there are some people that advocate for even contrast, which is kind of what you're saying, that like sometimes you might use heat, sometimes you might use ice, or you could even rotate that. And for instance, if I had a nerve injury and a lot of sensitivity in my hand, to help acquaint my hand with all the things in the world, that I might try ice on it sometimes and heat on it sometimes, to the extent that you can tolerate that. And so even for like a condition like fibromyalgia, where somebody might have some pain all over at different times, even rotating heat and ice may help with sensitive areas of particular sensitivity.
Okay, and you've already talked about stretching and even a plan or treatment plan with a physical therapist as a way to also help with pain. So that I also wanted to highlight. Now, any tips on mood and chronic pain? And I know this is a tough conversation to have. But what would you say? How would you address that?
I mean, I think the way that I kind of break it down is based on some of the teaching that I have, and really anything in terms of, say, medications. And there is a lot of co-occurrence of depression and chronic pain. In terms of medications for pain and medications for depression, this is interesting to me. Almost any medication that helps depression also helps pain. Now, why is that? Does that mean you're secretly depressed? No, not necessarily, actually. Now, there is a lot of co-occurrence of depression and chronic pain. If patients have significant pain, they're not able to be mobile, they're not able to do all the things they want to do, then that can lead to some situational depressive type of symptoms. So we do find that, what about mood and chronic pain? Well, probably the best plan is going to incorporate consideration of both of those things. Certainly, I have patients with chronic pain, and we might do a depression screener, and they have no depression at all. But on the other hand, there are other patients who do have significant depression that may be related to or worsened by their chronic pain issues. So again, a lot of the medications, there are some medications like Cymbalta, nortriptyline, amitriptyline that are in these antidepressant type of class, and they're also helpful for pain.
Okay, so there's a coexisting with both chronic pain and depression or mood disorders. Not all the time, but it's something to kind of look out for as well.
And I think the other way I think about it is really just, for just that patient with pain, some of those medications can help regulate your body's internal pain regulation systems, right? Like the pain regulation systems and the depression regulation systems, there's a lot of overlap in your brain. And so this is where some of these medications that help for mood can also be helpful for pain.
Okay. Awesome, awesome. A lot of useful information. So for those who are watching, who know someone who may be struggling with chronic pain, or you have some chronic pain issues yourself, I hope you find all of this information useful. We do encourage you to speak with your doctor, see your primary care doctor, get a referral to a pain specialist. And on that note, Dr. Merritt, if people are wondering, like this doctor is awesome. I like her vibe, and I would like to come see her or refer loved ones to her, where can people find you?
Sure. My business is Lifestream Health Center. We're located in Bowie, Maryland. We treat patients located in Maryland. So if you're in the DC area, we're just a stone's throw away in Prince George's County. And I'm going to give Dr. Tolu a link to our Facebook page, et cetera, as well to share. And would love to have you like our page and follow along as we put out good information for our patients to help their own journey with pain.
Thank you so much. I'm really excited to have had you here, and I'm sure our guests who are watching too have learned a lot just having you speak. We probably will have you on again as people have more questions.
Oh, I love
I'll
it.
let you know. So thank you for coming, and thank you all for watching. Those who are watching live and those who are watching replay and watching in replay. And I have a comment. Someone said, share with me. She'll bring her patient to come see you. I got you. And she's in Maryland. Yeah, she's in Maryland. Awesome. 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 I just thought like, yes, you're in Maryland. Awesome.
Right,
awesome.
right.
So I'll do that connection, which is great. And thank you, Dr. Clark, for watching as well. I'm glad that you were here as well. So on that note, it's been a pleasure having you all. Thank you again for watching. And if you or anyone you know is looking for an awesome, thorough, passionate family physician here in the Mansfield area in Texas, I am she. Thank you all. Have a good one.
All right. Thanks, Dr. Tolu.
Mm-hmm.